Good morning again. I think we have everyone joined now, so we will go ahead and get started for today. A couple things that I want to touch on before I turn this over to Carrie this morning is wanted to let you know that we have made some updates. Some of you may have noticed them, some of you may not have. No harm, no foul to our webpage, our COVID webpage. So I do want to share that with you at the moment. You will notice that those buttons that were at the top regarding county status, heroes, and stories from the field, to submit those are no longer there. We realized that the traction on those had long diminished, so no reason to take up that real estate that folks weren't using, and so you'll no longer see those stories listed over here. However, we will keep in mind and be attentive to other opportunities to be able to share information and have good stuff out there on what's happening. The next piece I wanted to mention is this email blast did go out this week regarding Relias listening sessions. For those sessions, some of you that have been using the Relias portals, the MODD content portal, and if you have a sub-portal of your own, you will know that Relias pushed out free courses early in the pandemic regarding hand washing and several other items. So we know that within our own content portal that we have had a lot of traction on those courses, lots of people taking them. So this is designed as a couple opportunities to listen and truly hear what else is needed, what is missing, what can be done to help support that, and how we can help, move getting good information forward. And then the next piece I wanted to hit on, just a reminder that there's this education page. Actually, I'll even back up one screen so that I can remind you how to get here. There's our main landing page, community support, education and learning. And this event training calendar has a lot of items on there that you may or may not have seen go out in an email blast. So I will tell you that as we speak, these are being reordered so that the newer date is at the top. I didn't realize that those were feeding in kind of backwards. So you'll notice that we have everything on there from some first responder advocacy training to we do have a one-stop link here to the Mo Health Net virtual training schedule. So this is a nice one-stop shop for you to come to check a variety of different training opportunities that may be going on even outside of the division. And with that, I am going to stop sharing my screen, and I'm going to give Carrie the controls, and I am going to let her run and get us started for the day. And Carrie, you are on mute.
Thank you, Heike. So the first thing I'm going to do is share my screen, which I think you guys have already seen. You can see it now. This is our daily situation report that we receive on the Fusion Cell. It talks about our total new cases that have been added since our last report. We do this, while it says every day, we do these meetings 3 times a week now. You can see that our average total daily cases are below 10, so that is good. That gets us out of the red zone for the state as a whole. They have added about just under 1,000 new cases in the last 24-hour period. And you can see when you look at this chart, this is where we were earlier in the pandemic. These are daily rates. They're colored here by the dark colors represent different weeks or months. And so you can see as we got into January, here these are January, that we started this steep downward decline. And we are down at these much lower levels, but we have kind of plateaued somewhat at these lower levels. It's good that we're at these lower levels, certainly, but we would like to see that downward trajectory continue. And I will share just a little bit about the fatalities that we have experienced. So, of course, this is from March, so the course of the entire pandemic. You can see our trends and our fatalities that we went up during this time period in November, December, and January. That is when we had such high rates of COVID-19 and, of course, corresponding fatalities with those high rates of community transmission. As I mentioned, we have since decreased greatly in that community transmission, and our fatality rates are reflecting that. So we are seeing much lower rates of fatalities, and we continue to expect that decline to continue with the increased rates of vaccinations within our communities. I wanted to also share with you, this next slide is also those fatality ratios by month. I'll point out April and May, because I'm not sure if you guys have seen this data yet before. It is available. It is out on our public-facing dashboards. April and May's rates are so high. That was the time frame when, as a state and as a country, we didn't have great access to testing. And so we were not testing and catching probably as many cases as were actually occurring in the community. So when you do that math to come up with that ratio, you come up with a much higher ratio. But you can see overall we're in this 1.5 to 2 range of fatality, which is also similar to what you see around other states and other countries as well. Some things that I wanted to share with you from earlier from Fusion Cell. There has been a lot of change in CDC guidance in the month of March, and so I did want to share this information with you. These guidances are out there. When I get done speaking, I will put a link in the chat to the CDC site that has a listing of all of these guidances so that you can go out and see for yourself and read through them. There are some caveats with some of them. For instance, public health recommendations for fully vaccinated people. And when you've been fully vaccinated, those really are written from the standpoint of individuals in the community. So what can I do with my family making my own decisions? You will notice as we go through some of these that they specifically say you still need to follow your employer's requirements and guidelines, policies, protocols. And that's really important because there's a different level of risk and things that I can ascertain and undertake for my own family, whether we want to get together with grandparents, not in a group setting or in a public setting, versus how you would handle things in a workplace. So that is things to keep in mind. You can certainly extrapolate from some of these things and apply them to work settings in some instances, but you do need to keep that in mind when you're reading through these guidances. So all of these are out here, all of these links we can share with you. We can actually share these slides with you after the presentation as well, make them available. But they have also put out updated guidances for healthcare settings as well. And so just real briefly, what these guidances are based on is really new research, new evidence. They're studying COVID and its effects and how it impacts populations and settings, et cetera, every single day. And so there's a growing body of evidence coming out to support these findings and to support these guidances. And so the first one is that the vaccines currently authorized really are effective, and they do prevent severe disease, hospitalization, and death. They do still provide protection even against the variants. So when they talk about this reduced efficacy against some of the variants, such as the South African variants, that efficacy is the ability of the vaccine to prevent a vaccinated individual from getting COVID. What they're finding more and more with these vaccines is even if I'm fully vaccinated and I contract COVID, I'm still getting that almost 100% protection against severe COVID disease, hospitalization, and death. So that's really, really good news. So that means these vaccines are working even against these variants. Maybe not as good as actually preventing you from getting it, but those are some really high rates anyway for a vaccine to prevent 95% of infections. It's fantastic, and we love it that it does that against the wild strain. It may be slightly lower than that against some of the variants, but still providing that almost nearly 100% protection against severe COVID disease. And that's really what we're looking for, is to stop folks from being hospitalized and dying of this illness. There is a growing body of evidence. There was even more information, I did not have time to read it this morning, put out that is showing more and more that fully vaccinated people are much less likely to have asymptomatic infections and also much less likely to transmit COVID to others. And so the reason they're pointing out about this less likely to have asymptomatic infection is because that's one of the big spreaders of COVID is asymptomatic people who don't know they have it, and they continue to go out into the communities because, well, they don't know that they're ill or that they're spreading this virus. And so it's great that those fully vaccinated people are much less likely to be an asymptomatic carrier and spreader of COVID. So this next bullet, fully vaccinated people cannot completely be eliminated as long as there's continued community transmission. So there's still risk, like we said, individuals who are fully vaccinated can still contract COVID as long as it's still spreading in the community. However, there are certainly benefits to relaxing some of the requirements and to going back to and resuming some of our normal activities compared to the risks. So with COVID mitigation and all of the things we're doing, masking, social distancing, testing, et cetera, there are certainly, and you guys have probably all seen it within your populations that you serve, there are certainly drawbacks to doing those things. You do get more isolated. People are missing out on those social interactions, those important life events, and that takes a toll on people as well. It takes a toll on them mentally, it takes a toll on them physically. Again, we're all about mitigation and reducing those risks, but we are never going to be in a no-risk environment for COVID or anything else. There's always a trade-off. How risky is it to get this food from a street vendor? Will it give me food poisoning? Maybe. Is it really, really good? Yeah, I'm going to take the risk. That's kind of how we approach life and we approach everything. So there is benefit to reducing some of these mitigation efforts and for people going back and resuming normal activities, some normal activities, sometimes still with limits, because the benefits outweigh the risk. So with the rates of vaccinations, with the decrease of COVID in our communities, with the rate of vaccinations among those you serve and or your staff, there's the ability to release some things and get back to quote unquote normal, getting back out in the community and doing our visits and monitoring, seeing people face to face. You just can't take away those benefits of doing those activities and those protective measures that are needed for those folks that we serve. And we can successfully greatly reduce the risk. So by still wearing our masks when we're resuming these activities, still looking at, you know, some appropriate social distancing, much like what's coming out from CDC even today regarding schools and the need for 3 feet of social distance if everybody's masking. Those are all things we can do to implement and still keep us safe, but get back to these activities that we need because we have those benefits of doing that outweigh the risk. Sorry, I got a little long-winded on that one. So what has really changed? Well, first of all, please understand what fully vaccinated means. People are considered fully vaccinated if you're getting the 2-dose shots. So if you're getting Moderna or Pfizer, you are fully vaccinated after you've had both doses. And it's about 2 weeks after you've gotten your second dose that you are fully vaccinated. For those individuals that get the single-dose vaccine, the Johnson & Johnson, it's also right about 2 weeks after you get that shot that you are considered fully vaccinated. So for non-healthcare settings, and again, I will caveat that this is really those guidances that were put out and meant for the general public. But in a non-healthcare setting, quarantine has changed. So if you are fully vaccinated, they're saying in a non-healthcare setting, a fully vaccinated individual does not need to quarantine for a full 14 days if you have been exposed to someone who had COVID-19. They do need to watch their symptoms, monitor their symptoms, but so long as they stay asymptomatic, then you should be free to go about and do what you want to do. There are some exceptions, and I'll point that out for us in particular. People living in a group setting, such as a correctional facility, a group home, some sort of congregate care, or people who are around someone who is at high risk for severe illness, then you should probably do things a little bit differently. So I'm fully vaccinated. My mother is not. She has underlying health conditions that make her high risk. So even though I'm fully vaccinated, when I interact with her, I will still wear a mask. I will still do most of those things that I'm supposed to, not because I'm concerned about me, but because I'm concerned about her. So for social distancing and mask use, you can gather indoors with a small groups of fully vaccinated people without wearing masks. So that was a big change and hopefully a big caveat or incentive to get folks to continue to vaccinate. You may also gather indoors with unvaccinated people from one single household. So think along the lines of grandma and grandpa who are fully vaccinated can now come over to the house and have dinner with their unvaccinated children and grandchildren. One household without masks, unless, again, here's that caveat, that there is someone living in that house who has an increased risk for severe illness from COVID-19. So if you, in the scenario I gave with grandparents, if the grandparents are fully vaccinated, but they're coming over to a house that has a child who is severely immunocompromised, then grandma and grandpa probably need to wear masks when they come over, and or the family need to wear masks when they come over. They can still visit, but you probably should still wear masks, and you should probably try to do as much social distancing as possible, but you can still have that visit. For non-healthcare settings, what has not changed? You still need to take those basic mitigations as far as social distancing in crowds in publicly and in poorly ventilated areas. So when you're going out in the public, if you're gathering with a bunch of unvaccinated people from different households, or if you're visiting an unvaccinated person who's at increased risk of severe illness or death. Any medium or large size gathering is a place where you still want to practice social distancing and wearing masks. Now, CDC does not really define what is a medium, small, or large size gathering, and there's good reason for that because it's really going to depend on where you're at. So, for instance, I'm sitting in a conference room right now by myself that is typically slated to have 10 to 12 people in it. Putting 10 to 12 people in here would not be a small gathering, and I would need to wear a mask because we have our normal ventilation, but it's a small room. And if we had 12 people in here, that would not be a small gathering for this space. If I were in one of our larger conference rooms that allows 50 people, 12 people kind of spaced out would be considered a small gathering. So that's why there's not actual numbers on there. They're still recommending that you delay your travel. Travel is a big risk factor for exposure to COVID-19. If you have traveled or you've been in some of these groups or you've been around someone who is sick, again, this is for a fully vaccinated person, you do need to continue to watch and monitor yourself for symptoms. If you develop symptoms, you need to get tested. And then if you are positive, you would need to quarantine. And then again, you still need to follow the guidances set at your workplace. So that's the thing I was pointing out. These guidances are really for individuals making decisions at home in private, not for employers. And so that is something that is important and you need to continue to understand. For healthcare settings, indoor visitation can be permitted with exceptions. So indoor visitation for unvaccinated residents, again, unvaccinated residents should be limited solely to compassionate care situations if the positivity rate in your county is greater than 10% and less than 70% of the people in the facility are fully vaccinated. So what they're saying here is if you have positivity rates of greater than 10%, I don't think there's hardly any in Missouri, if any at all at this point, that have that. We are pretty much below 5% or right at 5%, which is great. But if you are in a county that has a rate that's that high and less than 70% of the folks in your facility are vaccinated, then indoor visitation should not be occurring for an unvaccinated resident. Indoor visitation should be solely limited to compassionate care situations for vaccinated and unvaccinated residents that have current COVID infections. So if someone is sick with COVID, they should not be having indoor visits unless it's compassionate care. Vaccinated and unvaccinated residents in quarantine should also not be receiving visitors until they have met the criteria to be released from quarantine. And then, of course, if your facility is in an outbreak situation, it needs to follow the guidance from their local authorities and CMS, which visitation should really be paused. Additional requirements and recommendations on visitation is that you continue to regularly vaccinate folks. Ideally, unvaccinated residents who wish to be vaccinated should not start indoor visitation until they've been fully vaccinated. You should make sure that visitors know the risks associated with coming into the facility. Visitors can be screened, should be screened for symptoms when they're coming in, but they are putting out recommendations that you not require them to be tested. You can offer it with the Buy Next Now testing kind of things. You can do that if you want, but we shouldn't be requiring them to test as a condition of visiting. They should still wear masks. People should still wear masks. And then, of course, maintain that physical distancing as much as you can. So, work restrictions, fully vaccinated healthcare workers with higher risk of exposure who are asymptomatic do not need to be restricted from work. So if you have a fully vaccinated employee who has been exposed but has no symptoms, they don't need to be kept out of work for 14 days. There is that exception if that employee is severely immunocompromised. Those who have traveled, particularly out of the country, you do need to follow those travel recommendations, and I believe at this time they're still recommending quarantine for 14 days if you have traveled. Fully vaccinated residents and individuals should continue to quarantine if they have close contacts. Outpatients should be cared for with the following recommendations. So that, again, that's inpatient residents. We will send this PowerPoint out when we're done so folks can have this. Quarantine is no longer recommended for residents who are being admitted to post-acute care facility if they are fully vaccinated and have not had known close contact to a case in the last 14 days. As far as testing, that remains unchanged. So testing of people, if you're doing sentinel or surveillance testing, that remains unchanged. Testing for symptoms or outbreak testing, that remains unchanged. The same with PPE. They have made no recommendations for the discontinuation of personal protective equipment by healthcare professionals or providers. So that all still remains unchanged. We need to continue doing the masking. So there's still a lot that we don't know, and I said that the evidence is growing every day, and they continue to put out, they will continue to revise these things as we go through. But as I talked about a lot at the beginning, the benefits of relaxing some of our measures, such as quarantine requirements, such as visitations, such as allowing unmasked visits with small groups of fully vaccinated people, such as going back out into the community and doing our jobs while masking, social distancing, outdoor visits as much as possible. Those benefits all outweigh the risks because of the vaccines in the community, because of the reduced amount of COVID in the community, and the ability for us to do those other mitigation things, such as continue to social distance, continue to do outdoor visits or visits in highly ventilated areas, continue to wear the mask during the visit. All of those things make those activities a very low risk activity. Okay, so I want to move on. Actually, I'm going to check the chat because I haven't checked it in a while and I know lots of things came up. So I'm going to check the chat and see if there are questions. Real quick. So county statuses updated. We have not been putting those on the DMH website. We may get back to doing that specifically. What we were doing was interpreting all of the county data and then making a determination of visit or not, or remote only visits or in-person visits. At this time, we're going to all in person as of April 1. But on the public-facing dashboard, and I will put links in the chat when I'm done speaking, you can look at data for your own specific county at any time you like. So you'd be able to see their positivity rates, the number of individuals who are tested. It even has the red, green, yellow boxes based on the federal government's thresholds for COVID in the communities. All right, so I'm going to move now to, this is the state's COVID vaccine website. It's covidvaccine.mo.gov, and I'm showing you this for a couple of reasons. One, I want to show you the dashboard, which shows you vaccinations in Missouri and the status and where we are at. So as of today, we have had almost 2 million people in the state of Missouri initiate vaccine. I'm sorry, we've had 1.2. This is the number of total doses administered. So we've had almost 2 million total doses of vaccine administered in the state of Missouri. We've had almost 1.3 million people who have initiated, meaning if they're getting that 2-shot series, they've gotten at least 1 shot. we have almost 700,000 folks that have been fully vaccinated at this point in time, which represents 21% of Missouri's population. In the last 7 days, Missouri has administered 225,000 doses of vaccine. So this chart shows a breakdown of who has been vaccinated, and this is really good. Missouri has focused its efforts on these upper age groups because they are at the highest risk for severe COVID and poor outcomes, including death. So we have made great strides in those populations at getting them vaccinated. But we're also seeing great upticks here in these younger populations. Most of these individuals in here either have underlying health conditions that make them qualify, or they work in qualifying industries that would have gotten them vaccinated. If you missed the governor's announcement yesterday, they will be opening those additional phases. So in Missouri, we were lined out with phase 1A, which was healthcare workers by and large. Then there was phase 1B that actually had 3 different tiers. All of those tiers are open, with the latest one opening on March 15th, and that's allowing teachers is the big one to get vaccinated. That's occurring right now. On Monday, March 29th, phase 2 will open for all of the folks in that phase to make them eligible for vaccine. And on Friday, April 9th, phase 3 will open. At that time on April 9th, anyone in the state of Missouri age 16 and over who wants a vaccine will be eligible to get a vaccine. So please make note of those dates. If you or your friends or family have not yet been deemed eligible to get vaccinated, March 29th, phase 2 becomes eligible, and April 9th, phase 3 becomes eligible. What's really handy about this particular site is we do have vaccination data by county. This is Joplin, this is Kansas City. They have their own independent health departments, and they cross county lines, so they report numbers just on their municipal jurisdiction of Joplin or Kansas City. But you can see by looking at this chart what percent of the population in your county has initiated vaccine. So Adair County, 23% of individuals in Adair County have initiated vaccine. You can see how many doses have been administered in the last 7 days. You see the raw numbers of people who have been vaccinated. This can be sorted. So if I want to see it based on percent of population, you can click right there. Hopefully it'll speed up real quick and give it to me. It always goes slow when I'm trying to show it. And then you can see which counties have the highest percentage of individuals that have initiated vaccine. So it is, or you can look and see as far as doses administered, if that's what's important to you, or you want to see numbers of people that have initiated vaccine in your county, you can click here to see that. So St. Louis County makes sense, biggest population center in the state, has the most doses administered, followed closely by Kansas City and St. Charles and Jackson. Those all make sense. But this will be really handy for you when you're looking at things and trying to decide how much vaccine has been in your community. Let me check my list real quick. So for what I have on my agenda, part of it was for your next meeting, I think is scheduled for April 2nd. So I wanted to also put that out there as a date for you guys. And then to talk just a little bit, I'm going to stop sharing my screen now, about the Buy Next Now testing. We are still working with our friends at Health. We hope to have something out to everyone relatively soon for facilities, for providers who wish to use Buy Next testing either with your residents or your visitors or your staff. Buy Next Now is a rapid antigen test, and so there will be information coming out about that, how you can do it, the steps you have to take, the requirements that you will need to do. So that information will be coming out fairly soon. I've already gone over the vaccinations. For PPE, I wanted to talk a little bit about the PPE marketplace. So for those of you who remember, the state of Missouri put together a PPE marketplace. This was done through the Department of Economic Development. It allowed a kind of a one-stop shop where folks who needed PPE could go in and find people who manufactured PPE and get hooked up and connected with them so that you could order. That was in a time when PPE was almost impossible to get your hands on. That PPE marketplace will be shutting down as of April 1st. So you won't have that resource to go to. You can still utilize, if you were working through that resource and you identified providers who were providing you PPE and you've been working with them, you can continue to work directly with those individuals and access PPE through them. The marketplace will just no longer be active. For those of you who may have at one point in time or are currently requesting PPE from the state of Missouri through the Department of Health and Senior Services, that will continue. You will be able to continue using that as a resource and requesting things from them. And actually, I'm going to share my screen one more time because that made me think of something in the PowerPoint from today that I will show you really quickly, and hopefully you can see it because it's a little bit hard to read. But this is the type of PPE that is available at the state level. So if you see it in yellow, there's a couple of N95 type masks that are special request only because they're in very small quantities. But things that are in green, procedure masks, surgical masks, isolation gowns, face shields, goggles, gloves, they have received some additional gloves in. So many of these gloves that are yellow will be going to green. So that information is out there and you'll continue to be able to request that through the department. So I'm going to go back to the chat again because I think several things have come in. I'll stop sharing and I'll try to answer any questions that you have. So as far as the screenings, I see one in there about have the need to check temperatures before entering sites. Some hospitals have stopped this. Screenings are still recommended, but they're not really required. And so it's going to be dependent upon how you want to operate and what you want to do. What I can tell you is that DMH facilities, we are continuing to do screenings. But in some of our facilities, we are not doing screenings of staff who are fully vaccinated. So there is definitely some flexibility in this. How would you know if people in residential settings have all been vaccinated or not in the home? I have consumers that are not getting the vaccine. That's a really good question. I'm not 100% sure if you can, if you're the ones operating the residential setting, if you can ask those questions or not, or if you're simply providing staff for folks in there. So that's something you may need to just talk through with the individuals or with your providers as far as how you're gleaning that information.
Carrie?
Yes.
We might need to go through some of these questions in the chat and answer them as questions in our follow-up. Because some of this we'll just need to interpret through the divisions eyes too, and translate some of that CDC guidance for the division. So agreed. And I imagine we're going to get a lot of questions on this. So too, we may just need to answer some of these. If we have some extra time at the end, maybe we can come back to that. What do you think?
Yeah, I agree. There is one in here though that I do want to address about asking about that you shouldn't go into homes unless consumers and staff are all fully vaccinated. That's actually, no, that's not what we're saying. There are still, all of those mitigation efforts still work. So I did just want to put that out there on that particular one. Doing our work is not going to be predicated on every single individual in the interaction being fully vaccinated. But yes, Wendy, I agree. We'll go through the rest of these questions. And maybe we'll be able to do some of them here, or we'll have to put them out afterwards.
Yeah.
All right, that is all that I have. So I will turn it over to, I think, oh, Angie's not on. I think we'll turn it over to Leslie at this point.
Thanks, Carrie. I just have a few things. We're currently in informal requests for additional information, our IRAI with CMS on the comp CSW renewals and the PFH and MOKIDs. We're working through those. Those are due to CMS by March 29th. The division has also submitted to MoHealthNet for their review an Appendix K addendum for the comp, the community support, the partnership, and the MOKID waivers, requesting to add the health assessment and coordination services for individuals receiving home and community-based waiver services to coordinate care with local emergency rooms, urgent cares, and primary care physicians. You'll probably recognize this is the type of service that is currently being provided by Station MD. And last, the division is working on a table to list out the COVID-19 flexibilities approved through the Appendix K, the 1135, and all the division memos that have been posted. So as soon as that is complete, we will be posting that as well. So I'll turn it over to Wendy. Thanks.
Thanks, Leslie. Good morning, everybody. I know you've gotten a lot of really good information about what is coming out in the CMS and CDC guidance. We will continue to review that and digest it right along with you, and be updating our guidance on the website with information. But I'm going to spend my time just really focusing in on the monitoring pieces and the support coordination monitoring pieces that we said we're returning to in-person monitoring on April 1st. And it's brought along a lot of questions that have been really good. And your questions really do help us to improve our guidance and be clearer about it. So keep the questions coming. I think what I really want to remind people is that we've done this before. We've had the county map where we move in and out of remote monitoring and in-person monitoring. So you've done this before, and it's just like that. Monitoring is, as Carrie pointed out, it's a critical part of our work that we do, and it's a critical component of our safety net for our entire system. So it is not the same. Support coordinators are not visitors in the home. And with where we are in the state with our prevalence levels, our vaccination levels, immunity that people have gotten from having COVID, and the mitigation efforts that we put in place, it is a pretty low risk activity. And we just have to get back out and start seeing people where they live, in person, to ensure that they are safe and that the services are being delivered as required. It's a part and it's a requirement of receiving services. So we do everything we can to protect folks, but we've got to start getting back out there. And we know that this is going to be a transition. So, but we can't wait for everybody to be vaccinated, because as Carrie pointed out, not everybody will choose to get vaccinated. And those are risks that they take and make decisions they make as individuals, and live with those risks. But we need to start resuming some of our more normal activities. So we had a question come up about in-person meetings, and in-person means you are physically in the presence of the individual, as opposed to virtual, and you're seeing them using technology. That is not, we talked about it as face-to-face meetings, but what we're really talking about is face-to-face in-person meetings is you are physically present, not seeing them through a virtual piece of technology. In-person can include a combination of in-home and open-air monitoring to support the transition. So there is a lot of anxiety out there amongst people who even have been vaccinated, maybe be fully vaccinated, but it's been a long time since they've been out. And so there is a lot of anxiety about resuming some of those activities that everybody needs to really tune into. And how do we help to transition people to a comfort level where they feel good and safe about going out and having other people around? The isolation has always been a fear of what can come from that, and now we're going to start seeing some of the implications of that, I believe, in the weeks to come. There's been questions about holding ISP meetings, and we do believe that in-person is considered best practice, that everybody can sit around the table and meet together. But again, it has to depend upon the individual circumstances, and that may necessitate some flexibility. If people aren't fully vaccinated in the home and it's difficult to social distance, you may need to invite some people virtually still at this point, and then just work through it and transition over time as you can. You know, these are just not black and white decisions, which makes it so difficult and really does make it difficult to answer some of the questions that come about. There's just a multitude of factors that have to be considered. And as a division, we can't just lay out and say, this is how it is. We can't anticipate every situation and every circumstance. And so providers, support coordinator are going to have to work together to figure out what is appropriate given the circumstances of the individual. What kind of transition process is necessary. But when we talk about going back to in-person monitoring April 1st, we are talking about you're either doing an open air visit or you're talking to them through the window, through a door, through the patio door screen, but you're seeing them, you're able to see some of the house, or you are using all appropriate PPE precautions and entering the home. I know that some providers and TCMs have expressed that they are comfortable and ready to do that. And so you may absolutely do that as you all determine your comfort level actually getting in the home versus the open air visit. And there's going to need to be flexibility about that, but you need to be thinking through what a transition plan is. The division's going to provide more guidance. We will be digesting all the guidance that's come out that Carrie was referencing earlier. There's a lot of it, and our circumstances can be really different. So we will be digesting that and updating our guidance as it's appropriate. Keep in mind, it is guidance that we put out. It's not regulation. But we hope to have more information out to you early next week. So, like I said, this is going to take a lot. Yes?
Just real quick, I'm sorry to interrupt, but kind of watching the things on the chat, one of the things I wanted to make sure folks know and know how to use, I think we've shared it with you all before, but just to bring it to the forefront for everyone again, at this covidvaccine.mo.gov website, they list vaccination events all around the state. It will tell you if it's a booster only event, meaning that's a second dose, so you can't really register if you haven't initiated because they're doing folks who are getting their second dose. But they tell you if it's open. For instance, these that are in Johnson County for March 30th and 31st, they have a button for you to click to register. I have registered my own kids through Vaccine Navigator. Val won't mind that I'm sure she may have already told you she registered her family members through this. You get notifications of when vaccine is available in your area, when there are events going that you are eligible to sign up for. Most of you are all probably eligible already, so you would start getting notifications. There will be one in Platte County on March 26th that you can register for, and it goes all the way through. They update this all the time with these different events. So there's lots of events going on all around the state that you can register for to go and get vaccine. Several in St. Charles, St. Louis City, but also in the other regions of the state. And those I know are boosters only, but they will be getting back to them. Callaway County's got some going on. So you can come to this site and register, and they will send you emails and texts when these events are going on to get you signed up. You can click here for the Register Now button. You don't have to go and look for your specific region or your specific county's event. And you come in and complete this registration information. This is really painless. Like I said, I've done it. I've registered both of my children who are both over age 16. I haven't gotten notices yet because they're not yet eligible. But you answer their questions, you fill in the information, and it will tell you what phase or tier that you are in and if you are eligible. And if you are eligible, you will start getting notifications to get you signed up to get that vaccine. So I wanted to make sure everyone is fully aware that this tool is out there to help you, your staff. It'll get a little bit more difficult, maybe complicated for consumers, but certainly for you and all of your staff and people who are wanting to get vaccinated, this is a great way to do it. And in addition, Walmart, Hy-Vee, they are also Sam's Clubs. They're registering folks through their systems, so you can check your local stores to see if they have a way for you to sign up. They are also doing vaccinations around the clock at those facilities as well. So lots of opportunities to get vaccinated. Sorry, thank you, Wendy, for letting me interrupt. I just wanted to share that briefly with folks.
Okay. So sorry if I'm going to repeat a couple. I'm going to find my place here. Just reminding folks that TCMs, you know what is in your contract and what you need to provide as a part of the monitoring requirements. And you're going to have to build some of your business decisions around how you meet those requirements and the guidance that's out there. And just, it's going to take a lot of coordination and problem solving and partnership with families and providers. So I think we're all up for that challenge, and we will help sort through things as best that we can. In terms of the regional offices and operations, the regional offices will be opening up by appointment only. All the state departments are currently working through plans to resume operations and what that looks like. Everybody has, I think, found that the remote work has been successful in many cases. So everybody statewide is assessing job functions that can be successfully accomplished remotely versus in the office. What the technology needs are for going on long-term with remote work, physical space. Do we need all the space that we currently have if we're going to have a remote workforce? Employee satisfaction is a big part of it, and will probably lead to some positions being a hybrid model. And so just revising our policies to align with those decisions will take us some time. So I wouldn't wait on us to make any of, to model off any of your remote decisions, because as a state, we can move kind of slow sometimes. So it's going to take us a bit. But we are also resuming our monitoring through PR and TCM tax. We'll also be going back out in the field and working with providers on a case-by-case basis if there's issues or concerns around that. I just had 3 questions that came in. I think that they were pretty much answered in the text that, or in, what I have said. So I'm going to skip over those in the interest of time. And I will respond to those in the questions after the webinar. Thanks, everybody. And I'm going to turn it over to Clay. Clay, you're on mute.
Let's try this again. Good morning, folks. I was asked to talk about 2 topics. The first one that I'm going to go through is a question that we received about how long the relief that we have from the LOC being tied to an assessment that is 2 years old or earlier, how long that lasts for. So you might remember that we have 2 avenues that we sought to get some relief from rules and regulations. One of those was tied to the state declaration of emergency, and one was tied to the federal. The LOC one that allowed us to use assessments up to 3 years old was tied to the federal. So as you might have heard on earlier sessions, we were able to get that extended to 6 months after the termination of that state of emergency. So for the foreseeable future, we're still going to be able to use Mokabi's, Vineland's, whatever we used for that level of care formal determination that is up to 3 years old. Now, that doesn't mean that we don't need to pay attention to those dates, because we're going to come up on some this year that are going to exceed that 3-year timeline. So we'll have to pay attention to it, but it does not end on March 31st because it's tied to the federal Appendix K avenue that we use to get relief from that particular rule. Hope that helps. Secondly, as some of you might be aware, and you're probably tired of me talking about this over the years, it's been our intention to replace our current assessments with a new assessment, the Missouri Adaptive Ability Scale. The first kind of phase of that is about to kick in. So Missouri's contract with AAIDD, which is the organization that developed and owns the SIS, that ends at the end of June this year, and the division is not renewing that contract. Instead, we're going to be able to transition over to the MAAS, you can call it MAS or MOS, at that time. We'll actually do it a little bit earlier than that, a couple weeks before probably. Here are the advantages of going that route. The main one is it's a much shorter assessment to administer. So it only takes maybe 30 to 45 minutes as compared to 2 hours to administer. We only need one informant rather than two. It's able to be administered either in person or over the phone. Actually through WebEx would work. So we've got the ability to really meet the needs out there. We're currently developing the last part of the training that we're going to do in order to get the CIS administrators to be able to give the mass. That'll take place in the next few weeks. There'll be a period during which we're going to ask if it's possible that when a person gets a CIS, that they also receive the mask. They don't have to do it at exactly the same time, but I'd like to have that available if possible, just to make some last minute checks. I've got my current stats allow me to predict CIS scores actually a little better than a new CIS predicts an old CIS score. But that's somewhat theoretical, and I want to make sure that we get this as good as we can get it. The intent is not to lower rate allocation scores. The intention is not to have providers make less or more money. The intent is really just to provide a better assessment experience, do it more efficiently, take less staff time. So yeah, MAAS is the name, Missouri Adaptive Ability Scale. So this is a scale that we've been developing over the course of several years with MIMH, Missouri Institute for Mental Health. It's a norm referenced assessment that goes by age. And as we said, the intent long term is to have it replace the Vineland, the Mokabi, the PON, and the SIS. So the other assessments can't be moved over to the new MAAS immediately because that requires a CSR change. And we're in the midst of working through that very long and complicated process. So in any case, so short versions of both of these things, the need to get a new Mokabi for a level of care remains unnecessary if the Mokabi or Vineland is less than 3 years old, and that'll stay that way in the foreseeable future as it relates to the level of care assessment. And then secondly, sometime around the end of June, we'll transition from using the SIS for rate allocation scores to the new MAAS. So if you have questions, please leave them and we'll get back to you about that, but that's the information. How'd I do? Did I get close to the right amount of time? I hope so.
And I believe that wraps us up for today. I don't see any additional questions coming in about that. So thank you, everyone. Oh, let's see, just a second. There is one question there, Clay, that came in to me. It says, will support coordinators be giving the new mask?
Probably not. Certainly not for the replacement for the SIS. We're going to have to wait and see what the time requirement actually ends up being in a real world situation. Like I said, what we've done so far suggests that we can greatly reduce the amount of time that families and individuals and staff members spend doing assessments. If that's the case, then we can probably move ultimately to having it all done by division staff. But immediately for the SIS, that will absolutely be done by the same kind of folks, the same folks actually who were doing the SIS interviews. We're just going to switch the SIS folks over to MAAS folks.
Okay, and then one other question was, how long to change the CSR?
I wish I knew. You know, if I was a magic 8-ball and shook it real hard, I would say a year and a half, 2 years. Wish it wasn't, but that seems to be what we hear.
All right, and with that, we have kept everyone for almost a full hour today, so we're only giving you 3 minutes back, but thank you for joining us, and be watching for our next series of Friday webinar registrations to come out very soon. Thanks, everyone.